Hey guys, Miss Brown here. Just going to give you a little voiceover PowerPoint for the few pages of newborn reflexes on chapter 18 and for chapter 21. And you'll see that part of your readings, half the chapter is going to be this week, and then half the chapter will be next week with chapter 22 as a voiceover, since again we do not have class. So I try to break it up for you guys because I kind of felt like I wanted you to focus mainly on the physical assessment piece of this chapter, and then next week it'll talk about how to decrease stress in a hospitalized child, holistic nursing, those types of things. So I kind of felt like they were separate, so I'm trying to separate those out for you. As far as studying for this next exam, I really encourage you to read the chapters in ATI. You may see that some of the physical assessment values, such as temperature, pulse rate, respirations, and blood pressure, may be a little different in this lecture, but I'm going to go by what is an ATI. Okay, so you may see something on here, and I know I talked about the PALS, vital signs, and I'll talk about that as I go on, but focus on the values that are in your ATI, specifically, chapter 2. You'll see all those physiologic and growth measurements there on page 7, and so on and so forth. So if you're concerned about what range you want me to know, or I want you to know, look in ATI. Also, when you're looking through the health promotion again, obviously we covered most of that on this last test. However, just to make sure you understand, just focus on the physical development section of each of those chapters. And then for chapter 9, regarding pain in your ATI, they do a really nice job of breaking it down for you. And you'll see we'll talk about pain assessment tools later in this lecture. And on page 44, 9.1, they have a really good tool for evaluation by age listed out for you. So I think I would go to that and just check it out. Also, when it comes to pain, I don't want you to focus on the appropriate routes in that section. So on page 45 it says appropriate routes. Don't worry about that section because I'm not going to focus on the pharmacological piece of this at this point, specifically in that section. And then non-pharmacological measures are important, very important. Kind of knowing the pharmacological measures on page 44, that's good as well. I just don't want you to have to focus on the appropriate routes. Okay, so really go through that and build on this, on what you read in ATI based on what I talk about in lecture. ATI may have something extra or make more sense to you than what I'm giving you, or maybe I'm supplying you with more information that you need to know that ATI has. And of course, go through your chapter in the book as well. And in the book, I also want to point out, focus on those little sections that are about nursing insight, cultural diversity. There's these little sections within your chapter that are really good for you to look at. Critical nursing action, those are important, and focus on safety. So look at those little boxes. I'd really encourage you to focus on those as well, because they're there for a reason and they're very important. So really knowing how you're going to intervene as a nurse, what you're assessing, when you assess something, how can this apply? If I hear certain breath sounds, what does that mean? And how would I intervene? Or what can you expect? Things like that. So just kind of focus on those things. Hopefully that's helpful to you, and we will get started. So just like this last week, in regards to Piaget, Erickson, all that stuff, I have broken physical assessment up into age ranges to kind of help you better. I think it goes along a little bit more smoother, so we focus everything newborn to infants, so on and so forth. So this section is newborns to infants. Okay, so starting with the gastrointestinal system, I know this seems random, but we're going to start here. What you need to know about that with the newborns and infants is that the stomach is immature, but it does rapidly adjust. The capacity of the stomach is 30 to 60 mLs at birth, and then that will rapidly increase, so you're able to see that you're feeding the baby more volume in their formula or breastfeedings. They have a decreased esophageal sphincter pressure at birth that increases with age. So that's why they're burping up. When they burp, they may spit up, those types of things. So as they get older, the esophageal sphincter tightens, and so they're less likely to spit up their food. Their first stool is black and tarry and is known as the meconium. Um, and so, if you hear of a meconium baby, which Miss McSpadden probably has talked about or she will talk about, is when they lose their first stool while they are still in utero and they aspirate on that meconium, and it can cause lots of issues. So, meconium aspiration is definitely a potential problem. Stool characteristics depend on breast or bottle feeds. I kind of mentioned this the other week, but breastfeeding stool is kind of like a golden, looser, semi formed, sweet smelling stool. And then the bottle fed stool is going to be drier, more of a pale yellow, or greenish black to brownish color. So, an array of colors. But breastfeeding is pretty much that golden, sweet, semi formed stool. And then if parents coming in concerned about diarrhea and they're breastfed, a very loose or green stool is considered diarrhea. So that's kind of how you're able to differentiate between the two. This slide you have seen before. Last week or the week before, I can't remember off the top of my head, but just remember that breastfed babies eat more frequently and stool with every feeding, and then bottle fed babies eat less frequently, have a higher risk of constipation due to the makes it's a lot harder for them to digest that formula, and then they stool about 1 to 2 times per day. Just some information for you guys to know. Term neonates, so think a neonate that was born full term. Bodies are composed of 75% water, and you can see the breakdown between extracellular and intracellular is 40 and 35%. And then they will usually lose about 5 to 10% of their weight in the first week of life, almost all of which is water loss. So when they lose that weight, it's very common, and it's mostly water loss along with a few other things, but it's almost all of water loss. You don't have to know those. Just the 75% body weight composition, but do know that they usually lose 5 to 10% of their weight in the first week of life. And then you can see there what their fluid requirements are during the first 2 days and what it increases to. And then the biggie is that normal urine output is 6 to 10 wet diapers a day. So if you have a parent come in, ER, urgent care, wherever, out in the pediatrician's office, and they're stating that they've had 6 diapers over 48 hours, don't think, okay, 6 diapers, that's enough. Over 48 hours, it's 2 days. So remember, a day is 24 hours, and this sounds ridiculous, but I'm just trying to help you think through some potential situations. So 6 to 10 wet diapers per day, 6 to 10 wet diapers per 24 hours. Okay, as far as genitalia, there are some things that can occur that are fairly common, actually. I mean, not so common, but it's not so rare either. When it comes to male genitalia, I just want to make you aware of what it is right now. Hypospadias is the urethral opening on ventrum, the ventrum on the penis. Or on ventrum of penis, meaning below. So right here, sorry, on this picture A, you can see that's hypospadias. And then epispadias is urethral opening on dorsum of the penis, which is right here on B, above. And then you can see this picture up here I have for you, the normal urethral opening and just the different types of hypospadias that you may see. But just know the difference between hypospadias, which is on the ventrum of penis below, and then epispadias is on the dorsum of the penis above. So if you think E is above H in the alphabet and H is below E in the alphabet, that might help you remember. And then circumcision, surgical removal of the foreskin, and you just want to be able to educate patients, not patients, but the parents on taking care of that site while it's healed. Next, we have the skin assessment transition. And I guess there's not so much as a transition as just some things you need to be aware of. So the first one is erythema toxicum, and that's a newborn rash. And so you may see newborns with these tiny pimples that disappear within the first few weeks, and that's a common rash. And it's called erythema toxicum. So know what that is, know what that stands for. If the mom came to you concerned about these tiny pimples, after the baby is born, within the first couple weeks, it's erythema toxicum and it should go away. Mongolian spots are located over the sacral area, and there's a picture there for you. They're grayish, dark blue, or black. They can be very not vivid, but obvious. They may be more subtly colored, and you may not see them as well. But they're typically prominent in certain ethnic cultures from Asia, Africa, and the Mediterranean. But it can be in all shapes and sizes. Um, and the biggest thing with Mongolian spots too is that sometimes they're mistaken for abuse. So do your due diligence. Um, make sure it's just in that location. Does it blanch? Does it not? Having another nurse come look at it. Ask the parents, were they born with this? Because typically they're born with a Mongolian spot, or it may develop fairly quickly after the baby is born. So don't go ahead and assume that it is abuse, especially when it's in this area. I think it is more concern for abuse when you see it on the arms and legs. It's very rare that it's there, but a Mongolian spot can be on the arms and legs. So let's say you had a question that you are caring for a 2-week-old child and you noticed an area, dark blue area on the child's arms. What next step by the nurse would be most appropriate? So you wouldn't want to go ahead and jump the gun and say, I'm going to call DFACS or social services and figure out this child abuse. Think through, like, okay, is this really child abuse? Is there anywhere else on the skin? Ask the parents, were they born with this? And those types of things. Okay? Okay, as far as head assessment, we touched on this yesterday. As far as the fontanelles, let me get my little pointer again. Okay, so you have your anterior fontanelle here in the front, and then your posterior fontanelle here in the back. And so the anterior fontanelle is more of a diamond shape, and it closes at 12 to 18 months. It can last to 24 months, but for testing purposes, I'm going to say 12 to 18 months is when it needs to be closed by. And then your posterior fontanelle is more of a triangular shape, and it closes in 6 to 8 weeks. And the biggest thing with these is that you must assess them, okay? Especially, you can't bypass this. You need to assess those fontanelles. Of course, bulging or sunken fontanelles can be signs of a bigger issue. If a child is crying and the fontanelles are bulging, that's very common. However, if the child's calm and at ease and they're bulging, that's more of an issue. Because the brain's going to go path of least resistance, and that's showing there may be they have increased intracranial pressure for some reason. There's an issue. And of course, as you know, the sunken fontanelle is a huge red flag for dehydration, so you want to be mindful of that as well. As far as other assessments for the head assessment, the measuring of the head circumference is really huge, because if there's an increased circumference of the head that's abnormal, then that can be a bigger issue as well. So there could be some hydrocephalus, and we'll talk about that later in the course, some other issues. So the biggest thing you need to know, though, is just measuring the head circumference is important, because an increased circumference can also mean a bigger issue. And then in addition to that, the molding of the actual head occurs with normal when the baby is delivered. So if it's a vaginal delivery, it's common that they have a misshapen, elongated scalp head thing going on. And of course, typically the C-section babies will have that nice little round head for you. So if a mom is concerned about the elongation of their child's head, a vaginal delivery. Something that I want to make you aware of as far as head assessment that we'll talk about later in the course is the craniosynostosis, and it's the premature closure of the cranial sutures. And you can think of it as cranio is cranium, syn means together, and then ostosis means relating to bone. And it's just when two or more bones in the skull fuse together, and for some reason they're not really sure what causes it. It could be a cellular issue, it could be because there's more pressure on that skull when they're developing in utero. They're not really sure, but they're able to fix it with some either surgical intervention or maybe the helmets. And I'll show you the different types in a second. As far as our eyes are concerned, they start with that gray, brown, bluish eyes, and then they'll develop more of a color as they get older. Of course, you want that good old perla when you're assessing their eyes. And they actually have 2400 vision until about 2 years of age, and that's when they'll go 20/30. So that's when you'll see younger kids maybe have those glasses to help improve their vision, because they may be having some issues, not transitioning to a more 20/30 side of things. Ears, you want them aligned, responsive to noise. So any type of, big noise, you want them to startle, that startle reflex, like, whoo, that's a big noise. You want them to respond to that noise, and if they don't, they have unresponsiveness to the sound, it should be further assessed and investigated because that could be an issue. Nose, they are obligate nose breathers, and so you want to make sure you're keeping those nares patent. So look for any type of nasal flaring, increased respiratory rates. That will kind of give you an idea that maybe something's going on in their nose if they're just at home, or of course it could be something more severe, but you want to make sure that you keep those nares patent by bulb suction, or in the hospital you may do a little deep suction. And these are just the different types of the craniosynostosis. This is your normal head. So you have your sutures, you have your anterior fontanelle, posterior, and then you have your little gaps in your sutures here, okay? And then you have metopic, which is right here in the front. These fuse together too early. Sagittal, fuse together too early. Unicoronal, you can see how it's kind of lopsided. It's on this side, and then lambdoid, you'll see on right here. And again, we just don't know. You don't need to know the specific types. Excuse me. Just know what it is. You've seen this slide before last week, and just to kind of refresh your memory, maturation of the neurological system occurs cephalocaudal, head to toe, and proximo-distal, center to extremity. So the best table, the table I want you to go by, I've posted it in Connect as well for your viewing pleasure. But table 2.3 in your chapter 2 of ATI, that's the chart I want you to go by as far as when the infant reflexes disappear. So you will see reflexes on the left, what your expected finding is, and then the expected age is. So if it says birth to 4 months, know that reflex should be gone by 4 months. So if I ask you a question about palmar grasp, which ATI states it's expected birth to 3 months, and the child's 6 months old, and you're still able to elicit a palmar grasp, that's an issue. So you need to know the reflexes, you need to know what the expected finding is, and you need to know the expected age. And I am going to look at 2.3 in your ATI, page 10 of chapter 2 for that information. And on the right, you'll see the different reflexes. Excuse me. And, we looked at the videos yesterday. When it comes to nursing care of the hospitalized infant and newborn, you want to make sure you're encouraging parents to room in. Lots of times they'll have options to go to a sleep room. They may very well have to go home because they have a family. We understand that. Some might go to a hotel, they're on a McDonald's house. And you just want to encourage rooming in because it's good for the baby. And then it's also good for the parent. And then as the baby gets better, the parent may feel more comfortable to change diapers and start, it's time, you're going to be going home soon. You need to start that transition and start doing things yourself in the room obviously, besides giving medications and things of that nature, but you get the idea. Educate caregivers on safety in the hospital, such as keeping the rails up is a big one. You know, at home they have the rails up pretty much all the time, so they put the baby in the crib, but they may put the baby down in the crib and not think about putting the rails up, so just educate them on that. Educate caregivers on the fact that the hospitalized infant may regress in behavior. So they're meeting those milestones. However, maybe they're going backwards a little bit, and that's very common. So just assure them that this is a common finding in babies. And you'll see too, as children get older and say they're potty trained, lots of times they'll regress back to not being potty trained, and that's normal. Also, encourage caregivers to bring items from home that will give the baby security, such as a favorite blanket or toy. That's going to help them, be a little less stressed, ease that anxiety, any anxiety they may have. And that separation anxiety begins at 6 months. So you want to make sure that, something from home may help them out. And then you have your child life specialists, which are amazing, and you'll meet these when you go to clinical. They actually have a master's degree, and they are able to, they have tools and games and activities and all these things that you can utilize from them to help normalize a child or distract them or whatever you may need. And of course, you have those events in the hospital that help them feel normalized as well. This is that pairs chart that I showed you guys in class. I was like, know this chart. And then thinking about it, I just want you guys to know the breakdown of vital signs and whatnot in ATI, and that I spoke of earlier. And I liked this just because it did break it down. It's not just a broad range, but specifically newborn to 3 months, 3 months to 2 years. And this might be a good tool for you to have when you graduate and if you go into pediatrics, just because it's more specific. And you guys just don't need that specificity right now. So you just look at the vital signs in ATI. Pain management in infants and newborns. So, infants, of course, they feel pain. And the biggest thing for them is that since they can feel pain and can't talk about it, we need to assess it. So the CRY scale is something that is for infants up to 2 months, and it stands for crying, requires oxygen, increased vital signs, expression, and sleep. And those are the things that you're measuring on the scale. And I'm going to show you a picture in just a little bit. Also for cries, it's typically for postoperative pain. So it has 2 uses. Cries is for infants up to 2 months, and anyone, I'm going to say up to 12 months for postoperative pain. It may be longer than that, but for testing purposes, if you were to get an 11-month-old in postoperatively, then you would use the CRY scale to measure or assess for pain. Okay? And then any infant up to 2 months, you're going to use that CRY scale as well. FLAC has just one use. It's from 2 months to 7 years. It's pretty broad, and it's looking at face, legs, activity, crying, and consolability. And I'm going to show you a picture of that as well. This is your CRY scale for postoperative pain, and you can see where you have your numbers up here, your rankings, and then what you're assessing. Okay? So you just go over here, no crying, 0, 0. Obviously 0 is ideal. That means we're doing good. The more we have, the more pain they're in. Okay? So that's your CRY scale. And I'm just thinking for a second, that's why I paused. I think, if you had a specific question on a scale, I would not want you to memorize this. I would have this as an image for you to figure out what the number was for the scale. So don't try and memorize this. I would have a picture for you to add up the numbers and figure out what their ranking is on the scale, okay? And that goes for any type of scale. This is your FLAC scale, and same situation, face, legs, activity, cry, consolability, 0, 1, 2. Obviously, the bigger the number, the more uncomfortable they are. And again, I encourage you to look at that chart in your ACI book and with the different scales. I know too, I'm just going to pull it up real quick while I'm sitting here talking to you. You know, they have FLAC, it's 9.1. They have FLAC, they have numeric scale, which we'll talk about a little later, FACES scale, and then a non-communicated children's pain checklist. But focus mainly on FLAC, FACES, numeric, and then cries. They don't have cries in here, but cries is one that I want you to know. Approaches to medication administration in infants and newborns. Of course, these little guys are very squirmy, so you very well may need assistance doing or giving medications, especially if it's an injection. If it's an oral medication, they're very squirmy and they're a lot stronger than you think they are. Comfort measures after the administration of medication is very good. You know, they need the cuddle, they need some soothing, something to calm them down after you do that. So just keep that in mind. Okay, next we have toddlers to preschoolers. When it comes to vital signs, again, look at the ATI. I have this chart here, but I just left it here just in case. But I'm going to go by ATI. Toddlers 1 to 2 years, their heart rate's 70 to 150 depending on activity. Respiratory rate's 25 to 30. Preschooler is 3 to 5 years, heart rate's 60 to 120 depending on activity. Respirations 21 to 25. For this age range, make sure you tell them what they're doing. They're going to know, what are you doing? What's going on? And talk in simple, concrete sentences. Make sure you're on their level. Temperature-wise, you know, you'll take it axillary. Remember that after 3 months and younger is rectal, but older than that, you're going to start doing axillary temperatures. Of course, you're going to assess their heart rate, respiratory rate, assess for any types of distress or irregularity in their breathing. Blood pressure, something that's good for you to do is asking them which arm they'd like for you to use for the blood pressure. However, keep in mind if they have a PICC line, a central line, or an IV that's infusing medication or fluids, you do not want to use that arm. So make sure you're assessing that before you ask, because that's going to cause a trust issue if you ask them which arm and then you, oh, just kidding, you have something infusing. We have to use the other arm. So let them pick an arm if they can, and just tell them the cuff is going to be on their arm. It's going to give it a real tight hug, and they need to be really still. And if they stay still, the hug will be a lot shorter. You know, it lasts longer if they move around. So that's a good way of explaining it to them. And then pulse ox, allow them to pick which finger, and then demonstrate that it's painless. I always let them touch the light. You know, it's a red laser looking light and it kind of freaks them out. So I'm like, just touch it first. See, that's painless. I'll put it on my finger and show them it's painless. Let the caregiver put it on, show them it's painless. And that way they'll be more comfortable with it. When it comes to any further assessment, of course, we touched on this briefly. You want to listen before you touch, auscultate before you palpate. You are also going to really be palpating their abdomen, see if there's any distension, any pain there. Also, if they're around 18 months or a little below 18 months, you want to check that anterior fontanelle and see if it's still open or if it's closed, and assess that fontanelle specifically. And also their suture lines, see if everything's closing up there. Yearly, this group's going to need a height, weight, and BMI, hearing and vision tests as well, and then immunizations according to the CDC recommendations. And CDC is a standard for everybody. So if you didn't know your immunizations for this past test, you really need to learn them, because they're going to be on ATI, they're going to be on NCLEX, and I could potentially ask a question on this test, but I probably won't, but just know that you need to check on their immunizations and you really need to know them. And I feel like those that got it correct on the exam use that mnemonic that we talked about in class, but whatever helps you learn them, just learn them. I do want you to know how to calculate a child's blood pressure. And what this is going to give you is the low end of a systolic and a low end of a diastolic. So You may not necessarily know a range, but if you know this, you know anything above that is appropriate for that child. Of course, if it's sky high, that's an issue, but if you're like, oh, I don't know if that's too low, this is a great way to know. So systolic, you're going to do 70 plus 2 times age in years. Diastolic, you're going to do 90 plus 2 times age in years. And remember the rules of math, you want to do the math inside the parentheses first and then add. So what would be an acceptable blood pressure for a 4-year-old patient? Well, 2 times 4 for your systolic is 8. 70 plus 8 is 78. For your diastolic, you have 90 plus 2 times 4. 2 times 4 is 8. 90 plus 8 is 98. So an acceptable blood pressure for a 4-year-old would be 78 over 98. Do you know how to do this? It's not even it's gonna help you in clinical, but it's also gonna help you on the exam, and it's important to know how to do this. We're back to pain with these toddlers and preschoolers this time. And when children reach 2 years old, they're able to actually report their pain. They typically use that FACES scale that you'll see right there on your right. They kind of look at it and you say, how are you feeling? And they look at the faces and they'll point to the face or, maybe even give you a number, but usually point to the face. And in real life, it has colors on it as well. You want to make sure that you're assessing for causes. So is the pain caused by injury that they have? Do they have an infection on a site or something going on? Is it surgical, procedural pain? Do they have a disease that just causes overall pain or specific pain? Is it the IV site? Are they just scared? So you just need to talk to them and figure out where is this pain coming from. And then assume the pain is present just like all patients and treat accordingly. So listen to your patient. Even though they're children, they still require the same amount of respect. And if they say they're in pain, treat it as they have pain. And also you'll see there on the pain scale, the FLAC pain scale, because remember that goes up to 7 years of age for this group. So they'll typically use FACES or pain scale. As far as pain indicators, look for increased heart rate, blood pressure, respiratory rate. Anything increased there could give you an indication that they may be in pain if they're not saying it. Any type of facial expressions, the way they're moving, are they weary or fearful of moving? Are they catering to one area? Are they really restless? Also, they may cry, they're vocalizing something, vocalizing they're in pain, or they're crying, or they may be irritable and agitated. So that could be a cause or indicator for pain as well. As far as treating the pain with medication, just in general, you need to know medication choices. It's not a choice to take it. So you can say, hey, do you want to take your medication now or after your show, as long as it's within the time frame that you need to give it. But you can give them choices, but don't say, do you want to take your medicine? Because they're going to say, no, I don't want to take my medicine. So don't give them that type of choice. Just say, hey, do you want to take it now? You want to take it later? You can give them choices on what they want to take it with. If they're not NPO or have a special diet, you can say, hey, do you want to take it with some apple juice or a sip of Sprite? Of course, approved by the parents and the nurse. You can give them options there, so just remember that. Approaches of medication administration. So for toddlers, they may consider that you are punishing them for some reason. So they're going to hold their mouth really tight. They're like, I'm not taking that medication. So use some therapeutic play to kind of acclimate them to that medication. Maybe let them administer some fake medication to a doll so they can see how it works. Or if they're getting it through a needleless syringe or oral cup, let them play with those things and see that they're not a threat to them. And if you need to, you can also have the parents administer the medication. Of course, you want to watch it and make sure the child takes the medication, that kind of thing. But if the parents need to, you're certainly allowed to give them the medication to give it. And then use praise, yay, after they take the medication. And maybe even an incentive of a toy. Just all depends on the situation. Preschooler, they're a little older, so they're going to want to be in charge, take charge. So if they're able to self-administer an oral or liquid medication, They absolutely can if they're very closely watched. And of course, when you go into clinical, you're not just going to bust up in there and say, hey, sure, you can take your medication by yourself. Talk to the nurse, talk to the parents, make sure it's okay, and you're just right there with them as they take it. Also, parent can give the medication as well. May want to also use a little therapeutic play before giving meds depending on the situation. And then give them simple explanations about what it is, what it's for, because they're going to want to know why. So you can say, you're saying that your tummy hurts, so this medicine will make your tummy feel better. Or you're saying that this hurts, this medicine will make it feel blah. Whatever it may be. Or if it's not pain related, this medicine fights off bacteria, maybe not that specific, but just kind of give them a simple explanation of what it is. And then again, use praise when they take their medication. Next, we have our school-age children. When it comes to school-age children, that's ages 6 to 12, you want to do physical assessment a little differently. So you're going to do the least invasive parts first because they're a little bit more private, so do least invasive parts first. You want to look, talk, and then touch. So you're going to assess the child's appearance, muscle tone, skin, just kind of look them over. Then maybe discuss with the child and the parents, or caregivers, what's been going on? How are you feeling today? Any recent illnesses or problems? Since, I guess, the nurse before. If you're in the hospital, of course, if this is an outpatient situation, you'd be more specific. But don't talk over the child, talk to the child and let them talk to you and tell you what's going on. They want to feel involved in what's going on. Listen to what they have to say. So be non-threatening. Don't use any sudden movements. Stay at the child's level if you're able to. That's going to make them feel a lot less threatened and more comfortable. Use rewards if you're able to, some type of incentive. Say, okay, I'm going to do a little assessment, how to take your blood pressure, do these things. Once you're done, you can watch TV. Of course, you're running this by the parents, whatever. If you're by yourself, you can kind of do a little negotiating. Tell the child about procedure right before it happens to lessen stress. You don't want to tell them 30 minutes or more. You want to tell them right before. And I know that was a question on the test, but you tell these children right before it happens to lessen stress for any type of thing that could be pretty traumatic. However, when it comes to medications or food or something that's not like that, you can give them options and have some leeway on time. This group should also be pretty, more cooperative than the other. The older they get, they have more understanding and more comfort, but not always, but they should be more cooperative. And then you want to tell the parents that if they haven't already, teach them about good touch and bad touch, especially since now they're becoming more private with things that are going on in their body, things like that. But the younger you can teach good touch, bad touch, the better. Again, here's a lovely chart, but refer to ATI. In school age, heart rate's going to be about 75 to 110 depending on activity. And then your respiratory rate's going to be about 18 to 25. Physical assessments, obviously I'm keen on this auscultate before you palpate, so remember that. For this group, again, look at their CDC recommendations. Make sure they're up to date in their immunizations. They're still going to be getting yearly height, weight, BMI. They're going to start getting more family history, how they're doing in school, since they're now in school, how they're performing in school. Because if they're not performing well, maybe there's something either physical or emotional, mental going on that could be affecting that. Skin, look for signs of abuse, bruises, in various stages of healing, could be abuse, bruises on unusual parts of the body, any cigarette burns, other burns that are not easily explained. Look for those. Of course, you're going to look on those for all age groups, but I'm just kind of making you more mindful of that now. And then any type of rashes that could be present. Also, for GIGU, you want to assess for enuresis. Are they having any bedwetting going on, assess for encopresis, same thing. Are they stooling in their sleep as well? Those can be issues because they should be potty trained by then. So if they're having those things, they may need to be assessed for something further going on. Um, Assess for constipation, diarrhea, and any treatments that they might be using for these. Any type of neuromuscular assessment, you're looking for increased coordination, increased fine motor skills, increased balance. They should all be increasing, meeting those milestones, having being able to complete more complex tasks as they get older. And then 12 years old is when you start the scoliosis checks. Approaches and medication administration of this group, they're going to be even more cooperative. They fear loss of control and pain at this stage when they're in their hospital, so give them as much control and choice as possible. So again, would you like to take your medicine now or after or later? Give them as much control and choices as you can. They will try and negotiate with you. Give a choice, do not ask, as we have stated. Use praise and rewards. That seems to work for most age groups in general. And then this group also is going to want to know specifically, what these medications are for and how do they work? What are they doing? More complex type questions. And then depending on their age, make sure you're giving an age appropriate explanation. Now we have our adolescents. And for adolescent, again, same as you have seen before. Heart rate, 12 to 18 years, heart rate 60 to 100. We're starting to get into a normalized range as adults, as you've seen before. Respiratory rate 12 to 20. Height and weight, you're going to be checking those out as well. And I think those are listed in your ATIs. Something you need to consider when you're taking height and weight. Adolescents, especially girls, are sensitive to these measurements. So if you have to have them, maybe have them look away if they don't want to know. You don't tell them what it is. You can say, do you want to know what it is? And they say yes, you can tell them. If they say no, then don't tell them or set it up to where they can't see it when you're taking it. Physical assessment, of course, with everyone else, you're going to be doing a head-to-toe assessment. You're going to want to respect privacy because they're even more private. Inform the adolescent of your actions and explain rationales for your actions, why you're doing something. Focus on all the positive aspects of the individual, nothing negative. Don't address anything negative. Since they are private, they may want to talk with you privately. Maybe when the parents go to lunch, go in there and try to have a conversation with you because they may, with them, they may divulge things that they don't want to talk about when their parents are there. So, also, when you're doing a head-to-toe assessment, examine the genitals last because, again, very private and they're going to be a little horrified that that's even going on. HEADS is variations in nursing care, and HEADS stands for home, education, activities, drugs/diet, sexuality, and then suicide/safety. So HEADS is home, education, activities, drugs/diet, sexuality, suicide, and safety. And when it comes to drugs and diet, if a kid's emitting specifically for the drugs portion, if a kid admits to smoking cigarettes or inquires about other drug use, let me rephrase that. If a kid admits to smoking cigarettes, you want to inquire about other drug use because if they're starting to smoke cigarettes, that's a gateway. Nicotine's a gateway drug for teens. Of course, nowadays it may be something else, but usually in the past, nicotine can be a gateway drug for this age group. And then sexuality, of course, never assume that they're heterosexual, so you want to be mindful of that. Variations in nursing care, you want a consent from parent. Actually, I don't know why that HEADS thing. Variations in nursing care should be another bullet, so just move that down. Variations in nursing care, at this age group, you want to make sure you're getting consent from a parent, but also assent from the patient because they're old enough to know what's going on and they need to say yes to and agree to whatever's happening. You're going to maintain, of course, your confidentiality. So this is even more so since they start to get into that age range of adulthood and experimenting with things. Just make sure they know that you're really maintaining that confidentiality with them. Considerations in providing care as a nurse. You want to provide opportunities for socialization, so attending those events at the hospital, seeing if their friends can come and visit them, that really helps. Provide more chairs and other furniture to promote visitation. If people walk in and there's nowhere to sit, they're going to stay a lot less time, spend a lot less time in the room if there's nowhere to stand or sit. And then opportunities to provide and participate in planning and care, so that family-centered care, not focused, family-centered care. Now I get into the reproductive puberty for males. Excuse me. Puberty begins between ages 9 and 14, and it's done in about 3.5 years. This is when, this time the secretion of sex hormone increases. They get a little, interested in those types of things. They have a growth spurt between the ages of 12 and 14. Their adipose body mass will decrease and their lean body mass will increase. And then secondary sex characteristics that you will see are going to be the voice will start to deepen, they have their Adam's apple developing, and then their scrotum and penis enlarge. So just know the expectations of what occurs during this puberty phase in males. Reproductive and puberty in females. You can see that picture. That's about how, you feel at that age when it happens, but it can occur between ages 8 and 13, and it's completed in about 4 years. Breast development is a sign of puberty in females, and on page 799 of your text in chapter 21, you have those Tanner staging of development. A secondary sex characteristic, so make sure that you review that and you're still familiar with what those are. They'll have growth spurts a little earlier than males, so they're going to be about 10 to 12 years of age when they have their growth spurt. Lean body mass will decrease, adipose body mass will increase. So remember, in boys, adipose decreases and lean body mass increases, whereas girls are opposite. Lean body mass will decrease and adipose body mass will increase because the body is starting to prepare to childbearing age. They need a little bit more fat to help support that. And then the secondary sex characteristics, they're going to have menstruation, breast development, and then their pelvis starts to widen. Approaches the medication administration here, pretty cut and dry. Typically, they can do it themselves, but they may not be able to swallow pills, so don't assume that they can swallow pills. Check with mom, dad, caregiver, check with the patient and see if they can swallow pills before a doctor orders any of that, because that's the worst. If they get there and they feel it and they're like, oh, I can't swallow pills. So that's pretty cut and dry. And then hospitalization, common injuries for this group, of course, are going to be traumatic injuries due to risk taking, and then injuries related to accidental or intentional alcohol substance OD. And then environment of care, we're going to cover this later, but think about their environment of their care, where they are, where you're providing that care. And then we're going to get into nursing interventions in the chronically ill at a different time. And that is all for this week.